Welcome to the Protrusive Dental Podcast, the forward-thinking podcast for dental professionals. Join us as we discuss hot topics in dentistry, clinical tips, continuing education, and adding value to your life and career. With your host, Jazz Gulati.
Hello everyone and welcome to episode 22 with Dr. Barry Glassman. He likes me to call him Barry, as you'll see. So this is my first ever full intro and outro video podcast, and I'm glad this is Barry. He also featured in episode 8, which if you haven't listened to it, it's a great episode. I'd urge you to check it out. Episode 8 was all about anterior midpoint stop appliances and do they cause AOBs. So if you haven't heard that already, it's really great. You can hear Barry's passion in that, in what he believes, and I guess I want to give you some context in terms of what you're about to watch with or listen to if you're listening on the podcast, between the conversation between myself and Barry. Basically, what Barry teaches and what he's all about, and I'd heavily recommend going on one of his courses because it's a different way to see occlusion. And basically, the crux of it is that it's not the occlusion or the malocclusion that causes a lot of problems. Let's let you know, whether it's chipping or things breaking, TMD, which is a very loose term. It's not because of the occlusion per se, it's because of occluding. And what Barry always says on his course is nouns don't hurt people, verbs do. So the occlusion is not as important as the occluding. So if you've got someone who's like a 17.5 minute a day chewer, then they're not likely to cause that much problems in terms of destroying their teeth or TMD, because essentially what we talk about is the relationship between parafunction and causing repetitive micro trauma in the temporomandibular joint. It's quite we discuss a fair bit of anatomy at the end, so it's actually a good revision for that. And I'd actually encourage people to, if you're listening on the audio podcast version, to actually go to the video version, which some of you are watching right now, because Barry actually shows the temporomandibular joint and the disc, and he describes about the lateral pole and the medial pole, which is something that's not very well understood. It took me years to get the hang of that myself. So people might say that, Jazz, you just said, and you agree with Barry, that occlusion doesn't matter. So why do you, Jazz, go on so many different occlusion courses? And as you know, I'm a bit of a junkie for learning about occlusion. And I guess the answer I have, and I sort of touched on it a little bit on the episode, is this. Is that yes, occluding is the problem. And the occlusion per se is not as important. But remember that not all of your patients are going to wear appliances. And not all of your patients will adapt to one. And when you have an opportunity to rehabilitate someone or reorganize their occlusion for whatever reason, then you obviously want to set it up for a minimal stress occlusion, which is something I learned from Ian Buckle at the Dawson Academy. So if you're going to go through the effort of really placing lots of restorations, you'd be foolish not to design it so that when they do parafunction, they parafunction in a more dentally beautiful way, as someone recently put it on a Facebook group I saw. So that's why I continue to learn about occlusion, and it's good to have that hat on, but also it's really good to have Barry's hat on about, and actually occlusion doesn't matter, it's the occluding. So I like to marry them both together. I start off the discussion with Barry by introducing a parable that I read about. It involves 12 blind men and an elephant, and this parable is quite a famous parable in religion, obviously, but there is one version of it I read that is very relevant to TMD. And if anyone has read this parable, you will know exactly what I'm talking about if you have read it. Can you please send it to me? There's like a PDF version, and I've always remembered it, but I've never been able to find it again online. So if you know what I'm talking about, can you please send me that parable? So I make a bit of a pants of it, but you can listen to it anyway as I share it with Barry. So Barry is an oro-facial pain specialist, so I speak to him about how to manage these complex patients, what therapies he does adjunctively to, let's say, an anterior midpoint stop appliance where indicated. Also, towards the end of the episode, we discuss about anatomy and clicking joints, and whether an anterior midpoint stop appliance, as some people may argue, is contraindicated for someone with clicking joints. So you can hear about his view and the anatomy and how it relates to it. So the protrusive dental pearl I want to share with you before we jump straight to the episode with myself and Barry is I've had a lot of people ask me, because they saw that I went in the Smile Fast course, and they asked me about the Smile Fast course. Well, firstly, I want to say I have no financial interest with Smile Fast. I just went on their course, and I have the utmost respect for Tom Seeley and Mide, who are the founders of Smile Fast, clinical founders. And I have to, give it to them. They've set up a fantastic system. So if you're someone who's doing or planning composite veneers or rehabs, I think it's a great ROI, because I think I'm already at the moment spending time and money on digital wax ups, the stents that I usually make myself, and I think the whole package they've created is really slick. So I quite liked Smile Fast. Unfortunately, we're in the midst of the coronavirus crisis at the moment, so there's not going to be much dentistry happening for the next couple of months. But I like to think that I'll be using it more and more in my daily practice. So the pearl is, if you're sitting on the fence about Smile Fast, do it. I actually really enjoy the course, and I think it's going to be very clinically applicable. It's going to save me time and money. So that's my pearl shared with you. So let's jump to the episode with Barry and I, and I'll catch you the outro. But Barry, listen, I think
I'm having trouble with your mustache. You keep playing with it.
Everyone says that. All my guests, they say that. It's like, stop playing with it. But it's I don't know. It's just a natural thing for me to do. Every time I've been to a long course, the instructor at the end says, you know what, there's a sign, like when you're thinking, when you're in deep thought, or when you're interacting, occasionally you do this.
Then I'm in trouble, because you're thinking all the time now.
I generally am. My other trademark is really stroking my beard as well. So this is one of my professors told me that, and identified that, and so it's definitely a trait of mine. So now that we're on video, get used to it. Everyone, welcome back to another episode with Dr. Barry Glassman, who's in sunny Florida right now, and we've evolved since episode 8, where we talked about AOBs, have evolved into video. Neither myself or Dr. Glassman have had plastic surgery, which both our wives recommended, but yet we're still on video.
You need to call me Barry.
Okay, yeah, thank you, Barry. Barry, thanks for coming on again. That episode about AMPSAs, or anterior midpoint stop lines, and AOBs was very well received. It's had over 3,000 listens, counting on Facebook and on through my podcast platform and stuff. So the message is getting out there. Now, if you're listening to this and you haven't heard episode 8 of the Protrusive Dental Podcast, please listen to it, because I see it all the time still on social media, bashing these appliances, anterior only appliances, because people still think that the posterior teeth will over-erupt. We're not talking about that today, because we've covered that extensively and to a good standard, I'd say, Barry, on episode 8. So I think we're way past that. But I wanted to bring you back to do some more myth busting with occlusion.
I'm here.
So
let's bust them.
I want to let's bust them. Absolutely. So the first thing I'm going to ask you is, have you ever heard of a parable with the 12 blind men? Does that ring a bell to you? 12 blind men?
My wife is here. Did you ever hear a parable of 12 blind men, Sharon? 12 blind men. No.
Okay, I'm surprised. But okay, let me tell you this, and the guest, a parable. And then from that parable, I think will lead to our first question. I'm making it a fun thing, okay? So the parable is, the parable is set in India. And there's these 12 blind men walking through the jungle. I don't know how, through some guide or something, but anyway, they're 12 blind men, and they come across an elephant. Now, none of these guys can see the elephant, so each blind person grabs on to a part of the elephant. So we're talking about occlusion and TMD, but they're essentially attacking this elephant in the sense that one person is holding the elephant's leg and says, the elephant is, about yay big, and I can feel some hard nails, and the elephant is almost like circular in sort of cross-reference, in cross-section. And then the other person's like, no, I mean, the elephant is really hard. It's really, really tough. It's obviously holding on to the tusk of the elephant. And then the other person's like, no, I mean, the elephant's got like a long dangly beak and a hairy sort of a tail type thing. And no one can agree what this elephant is, right? And of course, the elephant is being perceived by each blind person based on the part of the elephant they're touching. Now, how can we relate that to TMD and occlusion? Well, if you go to a particular dentist, that dentist might say that TMD and occlusion can be treated by finding an interference, deleting that interference, and doing lots of funny things to the teeth to realign their jaws, and suddenly all the problems will go away, right? Another dentist might hold on to a different part of the elephant in this TMD and occlusion type elephant and might say that actually appliance A or appliance B will sort everything out. And another elephant entirely might say actually, another dentist even might actually say actually it's the combination of the chiropractor and physiotherapy and having Botox in the masseters is what's the right thing to do. And the fourth one will do a TMJ surgery. So this is the situation, I think, and I think that parable represents the current situation well, that actually depending on which specialty or which dentist or which clinician you go to, you will get completely differing opinions, and none more so than in the whole topic of TMD and occlusion. So what do you think of that parable in relation to TMD and occlusion?
I think we should keep it in India. No. So my wife is saying to me, "Boy, that's really good." They look at one part, but where may I think about this? Where is the problem? The problem with the parable is that we have an actual physical thing at the end that's true. It is an elephant.
Yes, and what the elephant represents
is what?
Parafunction.
No, I think the elephant represents, unfortunately, TMD. Okay. The results of, in other words, what we're trying to find, it's not the cause. I know we can get into blindness here is the possibly the cause, but it's not the cause that they're coming up with.
Yep.
It's the end result. It's that final thing. What is they're trying to identify what this is?
Yes.
And the answer is it's not just what you feel in the leg. It's not just what you feel in the tusk. It's not what you just feel in the ear. It's the whole thing.
The whole thing, absolutely. Yeah.
The whole thing represents, therefore, the what we're trying to identify, which is quote unquote TMD, and the problem is there is no such thing.
Yes.
So while I get it, because where the parable is really good, where it's really good, is that what it's suggesting is that there are contributing factors that we can do different things and wind up with a positive result. And then what happens is we assume a mechanism. We assume the mechanism based upon what we did, and then assume that that's the mechanism that was at play that caused the result, and assume, therefore, that the next person who shows up, the next elephant that shows up, that TMD thing, that I can do the same thing I did because it worked before,
yes,
and that's going to therefore work again. And if I don't do it the way I was taught, and it doesn't succeed, one of two things happen. Either this person's psychologically involved and they can't get better because after all, I did it as well as I could have possibly done it, and I know how good I am. Or I'm insecure and I think to myself, boy, if only I could equilibrate as well as the person who taught me. If only I could put in appliances in as well as Barry does. Wouldn't that be great? And the answer is you probably can. But in this particular complicated case, with its own unique factors, the mechanisms, the contributing factors may be different, even though we identified it as an elephant.
Absolutely. I think I told my story a little bit wrong. I think in the story, the way I read it, I've been trying to find this website where I read this parable initially, and it was on like this TMD type website. But I like the story better in the way I read it, because actually the elephant represented parafunction, and everyone's trying to treat a different thing. But what the author was trying to make the connection was that actually we need to, the parafunction and the trauma that results in an anatomy from that, be it the muscles that take a hit, the teeth, or the joint, is the parafunction is the main thing that we need to help. So that was that. And to what degree do you think is everything is responsible, and all the problems that we face is from parafunction. In the dental TMD occlusion type things that we're going to be talking about, parafunction has a huge role to play.
In my way of thinking, there are those, Jesse, that don't agree with us. There's a big movement in Italy led by a dear friend of mine, Danielle Manfredini, and they're spending a lot of time accepting the fact that parafunction may play a role, but don't really think that appliance therapy has much of a role, and they're looking more at access to. They're looking more at psychological component, and which blows my mind, because when most of the damage that a general dentist is looking at isn't significant pain, it isn't significant headaches. They're not the secondary care patients that I saw on a regular basis. The general dentist sees the wear patterns that you see. The general dentist sees the initial joint dysfunction, maybe some limited joint pain, but more clicking or a low-grade discomfort. This is what the general dentist is seeing, and and I'm having a little trouble dealing with someone telling me that these are access to patients. These are psychologically, and this is a physically damaged joint. That you can identify.
Yep.
And we can do. And how did it get that way? And what we know is that it got that way always as a result of some sort of trauma. In the absence of trauma, these joints, these ligaments that tether the joints, they don't get damaged. And so they get damaged not from the forces of function, but the forces of trauma. And the trauma could be micro trauma, which is the parafunction that you're referring to, or macro trauma, your wife punching you in the mouth on a regular basis. That's it. Or a fall, or
a road traffic accident, or
a football injury, for goodness sakes. So sure, you're supposed to be impressed that I came up with football rather than soccer. So yeah, I think from a general dental standpoint, parafunction is incredibly important and so easy, as we've learned, to control. And that's the greatest frustration. I think at one point in my life, Jesse, I really thought that I was going to be able to, I know this sounds, I thought I'd be able to help my profession more than I have. And I, in some ways, really look at my career as somewhat of a failure, only because I thought I could make the restorative gurus understand that what they were teaching was extremely important, but that if we would just add this simple parafunctional control concept, that is, we have study after study that shows with decreased forces with anterior midpoint stops from Hattori to Becker. I mean, it's overwhelming. The predominance of the evidence is overwhelming, and why not apply that to protect our patients and the dentistry we do for them? It makes no sense to me, and I thought it was so simple, but it flew in the face of them trying to make this restorative pain dysfunction connection, and they wanted the teeth to play a greater role, as though the craniomandibular system is dominated by teeth. It's dominated by teeth because that's what we see. Mm-hmm. That's what, the chiropractor thinks it's dominated by your cervical spine.
Absolutely, and the physiotherapist will think something different. And these are the people these are blind. We're all the blind, men in the parable.
Exactly. The neurologist thinks it's all, it's neuromuscular. It's controlled by the brainstem. We in dentistry try to create these mechanisms that we talked about. The neurology doesn't do that. Ask a neurologist the cause of a common headache, and what will they tell you?
I hope they'll say dehydration.
No. Well, the reality is we don't know. It's dehydration as you're drinking and I'm drinking coffee, causing increased dehydration. But the reality is that there are many contributing factors. We're still battling over what a migraine, the physiology of the actual migraine. It just changed 3 years ago. We no longer consider it a vascular headache. It's fascinating, right?
Mm-hmm.
So we don't know. There's a lot about science that we don't know, but there's very little about dentistry we don't know. And so dentistry needs to find answers, and it creates the very mechanisms we just explained, because they want to feel good about what they do. They want that cookbook. They want to be able to look at a patient and says, you have TMD, this is what I do for you. I put Botox, I adjust your bite, I use flat plate appliances, I use a tanner. I should know because I'm well trained by Dawson, and I see an increased influence of the restorative gurus, by the way, in England, which is fascinating to me. And there is a certain, I don't mean to be offensive, but there is a certain arrogance to knowing all the answers, and looks at the rest of us in dentistry as like we're the stupid ones. We don't understand what interferences do, and how important jaw position is, and we don't understand fencing, and some really absurd, when we look at the science, myths. And that's what my goal in my teachings, is to truly simplify this for the general dentist. It's not that complicated. Truly simplify this for the general dentist. Not so that you treat migraines, not so that you wind up treating, advanced headache referral patterns and oro-facial pain, but that you can look at that patient who is starting down that road, and you can make a recommendation that's so simple, and really help them, and then get to use your brain in a positive way. But they have to unlearn these things that are being brought across the sea. And being
Can you give an example to make it tangible to listeners about the most common things, misconceptions that people initially, when they come on your course, that they have? So what are these common myths? Because there's a question I want to ask you about parafunctional control. But before we get to that, what is the most common myth that you'd like to bust? What's the main message that you want dentists to get from this episode?
What do you think it is?
I think, having been on your course, which was great for changing my mindset, is that occlusion doesn't matter.
Unless you're occluding.
Unless you're occluding. So basically, for those who haven't been on Barry's course, I strongly suggest going. Now, that's not to say that, and this is my opinion, Barry, okay? That's not to say that you shouldn't learn how to do a full mouth rehabilitation for those who want to do it in the gold standard way. Because when you're reconstructing the dentition, you want to set it up so that you have a mechanical advantage within your dentistry in case the patient, all my patients at the end of a reconstruction get a night guard, right? They get an NTI, SCI, a FOS, whatever, all the appliances I use. So they would get an appliance, because I know that their parafunction will most likely still continue, because we know that putting their jaw into central relation will not stop their bruxism. Fiddling around with little interferences will not stop them from still parafunctioning. So if they parafunctioned before on their natural dentition and they destroyed their natural dentition, and then when you give them a full mouth rehabilitation, it's going to continue, right? But the whole reason we learn to do it in that way is that in case they forget to wear their appliance, that things are in a mechanical advantage for you. The forces are low. So that's what, that's an important part of it as well. I think for those who are giving the people the dentistry they want.
So therefore, the myth that you just expounded upon better than I can was that we build occlusions for function as opposed for parafunction, so that the concept
no, other way around, right? Other way around. We build the occlusion for parafunction.
For parafunction, not function. I'm sorry. Right.
Yep.
So thank you. So that this concept that I want even context all around to distribute the forces is nonsense.
Yep, absolutely.
That's the myth. I don't want forces to exist in the first place. So the first myth is that, or an understanding, the first big piece that's really hard to accept is that maximum intercuspation is pathological.
Yep.
What we test, tap, 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 shouldn't happen. May does a study that shows that there is some form of dental contact in a 24-hour period in a normal patient who may parafunction 20 minutes out of the 24 hours. Now, that dental contact is not MIP. That's incline to incline. That's the dental touching when you chew in some way that you could never ever predict. You know, when you check occlusion, you're not checking in any way, shape, or form how somebody chews. It's impossible.
Absolutely. So, I learned that on your
That's the
case.
first myth.
Sorry?
That's the first myth.
That's the first myth, that teeth shouldn't be touching in the first place.
Forces. That's not why I want it.
Absolutely. And the studies go back to the 1960s. I believe it was a graph, GRAF, that showed that in the classical study that in the way that they found it was like 17.5 minutes a day that teeth should be touching. And some studies expand on that in your sleep, it should be 8 minutes. But Barry, the reality is that I think I see wear patterns in about 90% of my patients. I do. I see it all the time. And it's because I'm looking for it that I see it. So I think for whatever reason, we have, the populations that we see are parafunctioning a lot. The issue is that people are keeping their teeth together for longer than that average 17.5 minutes. That's the problem. And
the reality is that all of the people who claim they were stopped, in other words, let's just say you've got a patient who's got facial pain and some joint clicking, and you do an equilibration, and in 3 months, they no longer have facial pain or joint clicking. The assumption is, therefore, what? My patient stopped grinding and clenching because they're better. Mm-hmm. And the reality is that whenever that was studied with EMGs, there was no change in the initiation of muscular activity that brought the teeth together while they should be totally separated at night as the muscles become more and more relaxed as we go deeper to sleep. So what is it that happened? You change the force vectors when they in fact did parafunction that got them within their adaptive capacity.
I 100% agree. Yep, yeah, absolutely.
So, and we can create ideal force vectors with an anterior midpoint stop. And that's the end of,
you're right. So, the anterior midpoint stop appliance can create the ideal force vector, but the word you use, and it's good that you say, is that it's parafunctional control, right? But I don't want people to misinterpret that. You're not controlling the parafunction, i.e. you're not stopping the parafunction in most people, right? You're controlling the parafunction, you're managing the parafunction, you're localizing the parafunction, if anything, and then you're improving or decreasing the force levels being produced by the muscle switching off, but the parafunction largely still continues, right?
So that's like 100% right. And I think that points out to me that I disagree with you. Mm-hmm. My term of parafunctional control isn't good. It is problematic because I never thought about that. I never thought that it would make someone think that I was suggesting we could stop parafunction. Parafunctional control kind of says that, doesn't it, Jesse?
When I first came across it, it was a Pav teaching for us in the UK at the time. And when I came to his lecture, I must have been a student at this time, right? And I literally saw the lecture title and I thought, okay, we're controlling it. This is going to be finished in a way. So how can we stop the parafunction? So yeah, but then I learned that actually, we're controlling it. We're managing.
No, we're controlling the forces as the result from it. So I need to rethink that. And when Matt listens to this, I want to change the name of the course. And now I'm teaching this weekend. I leave tomorrow for St. Pete. And I'm teaching a 2-day course with Jim Boyd, who is the creator, the inventor of the NTI. And he came to me and said, well, what do you want to call the course? And I said, Occlusion and Parafunctional Control for the general dentist. And he said, oh, that's great. And I got to be honest with you, I have many weaknesses. Some of them I don't want to discuss right here. But I'm unfortunately my wife's not in the room because she would quickly discuss them. So I have many weaknesses. No weakness is greater than my inability to properly entitle a course. I just suck at that. I can never come up with good titles. And the one I thought I had, thank you very much, because you've pointed out to me that it's not so good.
No, that was not my intention. That was not my intention. That was just in case any young dentists out there thinking, okay, this appliance is going to stop someone's parafunction. No, it's not. We're just, in your way, controlling it. We're reducing the forces. We're changing the force vectors. We're then creating an environment whereby the patient can start feeling better if they are symptomatic, or if they're not symptomatic, then they can be protecting, depending on the reason that you're using the appliance.
We often, and this also upsets a lot of people, because I don't think, as you know, keep in mind my practice, Jesse. My practice was truly secondary care, severe pain patterns, oro-facial pain, migraine patients that were recalcitrant to abortive and preventive therapy. Very, very complicated patients, and a great number of them got significantly better with our therapy. Not all of them, and by
your therapy, you mean usually like an appliance, right? Like
almost. So that's absolutely fascinating. So when you when you look at a history of mine, like someone like me that's an old codger and started looking into pain therapy for dentists as the dentist in the late 70s. So in the late 70s, we really didn't know much, and we were taking every jaw and we were shoving them back. I was with Niles Goucher, and we were taking a jaw and deprogramming it and then shoving it back till we heard a clunk, putting the condyles in the external auditory meatus, and then and adjusting the bites, and some of our patients got better. Then I met Harold Gelb, and Harold Gelb said to me, no, you can't, you're putting the condyles in the wrong place. And he made mincemeat of me at a lecture at Temple University in Philadelphia. And then he met me afterwards, and he took me to dinner and he said, Barry, you've got potential. And then I worked with him for 7 years in his office. And then when I realized that what he was doing wasn't quite as successful as he claimed he was. And
because the Gelb appliance is literally the opposite appliance of
Exactly. So yeah, and then I started studying with neuromuscular people, and I was tensing people and making them, but when I was with the Goucher people, when I was with and then with everybody else, I was using. At that point, we were teaching deprogrammers 6 to 11, which is upper 3 to upper 3 to 3, and we were putting those appliances in, and then they came back and said, "Oh no, we got to take these appliances out. They're going to cause trouble." And I said, "Okay." And I took the appliances out, and in my private practice, what I found was all my patients started to have pain again. So without telling them, I started putting appliance back in. This is about when I meet Jim Boyd. And Jim Boyd's going, oh my God, this, and then you have to do this, you have to do this. And I met him afterwards, after his lecture. I said, oh my God, this is amazing. He said, well, did you find that you have to, for example, you can't let the canines touch? I never thought about that, but I lied. And I said, oh yeah, you can't let the canines touch. And then I went home, back to my practice, and removed all the canine contact. And lo and behold, then all of a sudden I make this realization. I said, we've learned all this stuff. I mean, I've learned how to diagnose. We do blood studies. We do all the things you're supposed to do. We know when you're supposed to do imaging. We know, because these are advanced patients. But when the simple ones, in the beginning, you'd get so many simple cases where it's a click, it was some degenerative joint disease, there was some oro-facial pain, some stylomandibular insertion tendinosis, some referred pain patterns from sprained ligaments. These were easy to fix. I would give these long treatment plans, and it started with an appliance, and they'd come back 3 weeks later, and I said, okay, now we're going to start the supportive therapy, and the patient would say to me, why? I said, what do you mean? She said, I'm better. I said, no, you can't.
It's what in the US a lot of dentists call phase 2, right? So your phase 1's the appliance, and phase 2 would be a 6-figure.
No, this is still phase 1. So this was supportive therapy. I never ever did phase 2, where I told people you're now in a new jaw position. That's that's the neuromuscular concepts, and
Uh-huh.
that I knew all along. I never ever recommended that. So having said that, but even phase one was more complicated, and then it suddenly struck me that these patients didn't need me. They didn't need the background I had. They didn't need the training I had in sleep and pain. They didn't need that. They needed a dentist who understood parafunctional control. And if a general dentist could do that, then they could send it to me for the supportive therapy that they would need, but they would already have been started with the appliance therapy that for the most part got them all better.
So for the most
So
patients, for the simple patients, they would get better with the appliance, with their dentist.
that's what.
And what I want to know now is what kind of support therapy, adjunctively, do you think works well?
Oh, okay,
I mean, that might be a complicated question because it really depends on the exact diagnosis.
so I'm not going to go into our patients with MS and or MS patients or patients with more complicated altered autonomic system responses. I'm not going to go into that. I'm just going to talk about that patient with degenerative joint disease. So the patient with degenerative joint disease, there's no better way to treat them, interestingly enough, than with an anterior midpoint stop appliance, even though one of the big myths that we have to fight is that you can never use an anterior midpoint stop appliance in a patient with a joint problem because you'll compress the joints. Well, the study after study, and we show this in the course, shows that that's not the case. That we don't compress. This concept of taking the condyle with no posterior support, and and therefore allowing the condyles to move up and back into the retrodiscal tissue doesn't happen, and we have tomographic proof of that.
And because I'm a real geek, is I respect and I agree with that, but I like to find out why and the nitty gritty of each bit. And the way I rationalized that was the function of the anterior temporalis, the vector that does, actually doesn't allow it to go all the way back.
So the anterior temporalis is a little more vertical, but the masseter temporalis is extremely anterior. Remember the origins is the inferior portion of
the zygomatic,
zygoma, and this attaching. So the attachment is
Okay.
it's really so when you combine, when you add the force vectors, your physics finally played me some
Finally, all the physics, the A level, everything. Yeah.
Oh my God. So but when you combine the force vectors, it's furthermore. Remember what we were taught. Another myth is the first 20 millimeters of opening is pure
Rotation. It's not. It's I think MRI has shown that, right?
Translates immediately. Yeah, and it makes sense because the lateral pterygoid is it contracts at the same time that the other suprahyaloid. Yeah. And so when it contracts, the only thing the condyle can do is move forward. Well, as it's moving forward, how in the world is it going up and back? Mm-hmm. Because it's moved forward, because there's something between the teeth. You're not allowed into full closure.
Mm-hmm. So I didn't think about that. So that really scratches that itch I had in a really good way. So that's brilliant. So not only is the vectors of the muscle, which I already sort of had in my head, it's also the fact that actually the lateral pterygoid is already activated because you're slightly open. So it is actually giving that sort of anterior position of the condyle.
Right. I'm not sure the lateral pterygoid is activated, but it's not allowed.
It doesn't allow it to go all the way back. Yeah.
Can't go back. Can't go back. And we see that when we take someone with a just a deprogrammer, just an NTI in or an SCI, and we take a picture of it, the condyle's down and forward. Mm-hmm. We didn't bring them forward.
No.
So the answer is that so with degenerative cases now. What else do we want to do? Well, do we want to go if it's severe pain with a degenerative case, do we want to put them on steroids for a short period of time? Do we want to put them on NSAIDs for a short period of time? Do we actually want we use a process called iontophoresis that uses electrical current and the process and the concept that likes repel. So it goes two phases, a positive and a negative phase. And the positive phase forces the lidocaine, which is a positive charged local anesthetic, through the tissue and then negative forces negatively charged, which would be the steroid. And so we can get steroid into the joint without an injection.
Mm-hmm.
So we can treat them, give them 6 sessions of iontophoresis, put them on, again, the splint therapy, which everyone would think, oh my God, you're crushing the joint. And degenerative disease gets now under control.
Mm-hmm. Mm-hmm.
And we have less pain and less dysfunction. Yeah.
What about the role of a massage and physio?
Okay, so it's interesting. Don't get me wrong, physio can be very, very, very helpful in some cases. I personally have found and teach that muscles are overrated, ligament insertions are underrated. So muscles tend to be the ones that are doing the pushing. They don't tend to get hurt. We don't even understand muscle pain very well. We know that there's an increase in glutamate, for example, in patients with muscle pain, but we don't really understand much about how muscles and why muscles hurt. And to be honest with you, there aren't many people, when I palpate the masseter, despite pain, reported pain, where does it hurt? It hurts here. Now palpate the masseter, and what do they say? Could you do that a little bit more? That's just what my grandmother does. They love that.
It's the same with the temporalis. It's like, oh, that feels really good. What's your hourly rate? They say.
Exactly. Or if you find a sore spot, that's why they're getting anterior temporal headaches. No, anterior temporal headaches are not sore anterior temporal muscles. And so I think muscles are overrated. And muscles are the ones that, if you're standing at the edge of the cliff and someone pushes you, the object now wouldn't be to fix the pusher. It's to treat the damage that's done as a result of the pushing.
Mm-hmm, mm-hmm.
We tend to look at the pusher.
Yeah, yeah.
I don't think the pushers are the issues.
Interesting.
So, and again, so physiotherapy can really be helpful in patients where we've reached our limit and then we want to increase the range of motion. Physical therapy can be really helpful because some dentists don't want to do the iontophoresis and do the ligament insertion injuries where we do a lot of injection therapy on those patients. And we don't, I used to show those clips of me doing these stylomandibular ligament insertions and masseter insertion injections, but I don't show them anymore because the legal world's gotten kind of interesting, and I don't want anybody getting in trouble because of what I taught them. And the use of extra oral injections in some in the States, and some I just try to defend of some really good practitioners in Sydney, Australia, because they were doing trigger point injections. Now, I'm not even talking about trigger point injections. I think they are really overrated. And I may think that because I may not be as good at them as some other people. I just wasn't, personally, I couldn't find the trigger points as readily as some people claimed they could.
Interesting.
I'm not saying they didn't. I'm saying, I'm not talking about them. I'm talking about me.
Yeah.
And I didn't get as positive a response from doing trigger as I did from ligament insertion injections. So we look at the stylomandibular ligament, the masseter insertion, and the major insertions in the posterior cervical. A lot of our patients that wake up in the morning and they say, "Do you wake up with a headache?" They say, "Oh yeah, where is it?" And they'll point right here. They'll point right to the attachment to the internuclear line. And it's fascinating because when Levine's group, Cato, did a study, what they showed was right before these muscles contract, the temporalis and masseter contract, right before that happens, the elevators, the depressors contract, almost as in an attempt. I'm careful. I don't try to predict why God or Darwin's doing what they're doing, but almost as though to protect the structure so that you don't slam shut, and it braces the mandible for the masseters and temporalis when they suddenly contract. At the same time, the posterior cervical muscles contract, and they stay contracted in what we call isometric co-contractions during the clenching activity. Well, when you're pulling like that on constant contraction, where's the injury likely to take place? In the muscle itself? No. Where at the enthesis, where the muscle attaches to the infranuclear line. And
this is whenever I'm doing a muscle examination, I'm not expecting to find a positive result when I'm actually massaging the meat of the muscle. It's always at the origin and the insertion where you'd get a positive, if there is a true positive response, right?
Exactly. So we palpate the origin of the deep cervical semispinalis and spinalis capitis here, and we show people how to do that. And that injury is the most common one to improve with parafunctional control.
There we are. I'm actually learning a lot, even though I already thought, I'm getting the hang of it. Then you throw these new things out there. So yeah, muscles important, but ligaments maybe even more is what you showed there, and ligaments and PCs, and so that's very interesting.
I think of all the things we talked about tonight, I think the thing that I would like, if someone said to me, what was a message that you are hoping that someone watching this is getting? And what that message is that we as dentists shouldn't be afraid of unlearning and learning about occlusion, that it's not as complicated. It's not as complicated. The answer is we don't want people occluding. And we'll show you how to protect people from doing that. And sometimes a flat plane appliance is the right appliance. Sometimes a Tanner appliance might be the right appliance. More often than not, an anterior midpoint stop is appropriate. And we show you why and how. And to understand that this is not for the pain specialist. This is not for the guy that wants to treat migraines. Though it'd be awfully nice if some of your patients' migraines decrease in intensity and frequency as a result of your therapy. But I would never make that promise, or never make that diagnosis as a dentist. I diagnose bruxism, nocturnal parafunction.
I think it's important to communicate in the correct way as dentists to our patients, because we're not, legally we can't be treating these migraines. So we should be very much like, look, it's interesting that you get these migraines. I want to help reduce your forces, because I don't want you to hurt your teeth and hurt your jaw anymore. Let's see how that goes. Some patients it helps, some patients doesn't, but I'm not treating you specifically for that. I'm treating other things.
The good news is that while we protect your teeth and your jaws and your joint, a lot of our patients with migraines tell us they significantly decrease in intensity and frequency. Let's keep our fingers crossed. Wouldn't that be great? Hello.
That's a good way to put it. There's actually so many questions, but I'm gonna have to cut it short because we're already coming up to the almost 50-minute mark. It's very easy chatting to you, Barry. So you touched on the occlusion course stuff. So I'm hoping to come see you in Glasgow in June for the part 2, because I've done your part 1, but I'm gonna do the part 2 as well in June. I think you're in Glasgow and in London.
Yes. So we're in I don't have the dates right in front of me. You could have them. But the date,
I'll put them on.
That's great. And the dates are, so there's a 2-day in Glasgow, where it's a 1-day, the lecture, and then the second day is the hands-on. And then we move the following, that's a Friday and a Saturday. And then we move to London the very next week, and we're in London doing the exact same thing Thursday and Friday at the BDA.
Brilliant. So then I'll make sure the details are all there. So one more question then I thought of is that some people say that you shouldn't prescribe an anterior midpoint stop appliance for someone who's got clicking. So anatomically, I can see where they're coming from, because that is disc displacement. So the disc is now usually a bit more anterior. Not always, because it's a bit more complicated than that, because it could be lateral pole and the medial pole could be fine. Then henceforth, an anterior midpoint stop appliance should not be contraindicated. And I know over a video, even a podcast episode, for those who are new to this and learning about this in the anatomy, they're like, what the hell am I saying? And I've been there. But I think once you learn more about this, the anatomy, I think once you learn the TMJ anatomy, you can really visualize it better. But in that scenario where you have anterior disc displacement, and you do get some degree of seating just from the lateropterygoid relaxing, right, with the anterior midpoint stop appliance, there is a potential that it could be impinging on retrodiscal disc tissue. My thinking, and please correct me if I'm wrong, Barry, my thinking is that a lot of times, because the muscles themselves are reducing in force, that doesn't seem to be a significant issue.
I don't even know where to start. I have to unpack that. Okay, so let's go back. This disc is fibrocartilage. It's very bony-like. and it's attached, if I can show you, it's attached, if this is my condyle, it's attached on the medial pole and the lateral pole.
Yeah.
It's attached anteriorly by the superior head of the lateral pterygoid.
Yeah.
Right? And posteriorly by what's called the retrodiscal lamina. We used to call it a posterior ligament, but it's not really ligament. It's irrelevant right now. And then this thing is well tethered, and wherever it goes, there's an inferior compartment, the superior compartment, and it stays well tethered, and it stays interposed between the condyle and the glenoid fossa. And it's smooth, and there's a temporomandibular joint ligament around it. It's
and the lateral collateral ligament, and
the synovial fluid. There's a temporomandibular joint ligament around the whole thing, Jim.
Mm-hmm.
This is the lateral collateral ligament. This is the medial collateral ligament. Okay,
Mm-hmm.
so it attaches it at the lateral pole and the medial pole.
Yeah.
Okay, lateral pole and the medial pole. Lateral pole, medial pole. Now,
Mm-hmm.
the superior head of the lateral pterygoid runs medially because it attaches at the lateral pterygoid plate of the sphenoid bone,
Yep.
which is in the sort of closer to the midline. So when it contracts, it tends to do damage to, more often than not, the lateral pole. And when it does damage to the lateral pole, the tethering is now altered. It's weakened. And here's the thing about ligament damage. It tends to be permanent. It doesn't heal. Right? So now the
it doesn't heal, and also the only way is south. I mean, it could only really, throughout someone's lifespan over the next decades, the eventual, and I've heard some people say this, that eventual pathophysiology is that eventually, if the forces aren't controlled and the micro trauma continues, then it's only going to get worse and worse and worse.
It's get worse. And just keep in mind that a third of our patients who are adults without symptoms have internal derangements that are significant. So I don't want to overstate the need to stop this from happening. And we go through how to make the decision whether or not someone needs to be treated. And it's not simply because they're clicking. It's just not that simple. And so now this disc tends to be anterior and medial. Just tends to be that way because the lateral pole is been compromised.
Yeah.
And if it gets that way enough, there's a big, thick posterior rim, and then when you open, the click is the reduction, the rim coming back over the condyle. That's what makes that click. All right. Now, how did it get that way? Well, it got that way through some sort of trauma to this lateral pole. You are right. If we don't stop that trauma, will this get worse? And the answer is, I don't know.
Back to episode 8. I don't know. Yeah, that was a revelation. Absolutely. It's not known.
I don't know what's going on. I don't know. I can't say. Is the patient still grinding and clenching? I don't know.
Yeah.
Because they've got wear patterns on their teeth. Does that mean they're grinding and clenching? No. That means they grinded and clenched. But it's not time stamped. I don't know.
Yep.
So now the patient reports that, lately the click is getting worse. All right. Now, I don't care where this disc is. What's causing the click? Forces. What do I think? I think they're grinding and clenching. When are the forces greater, more destructive? During eating or during dysfunction? During parafunction.
Absolutely.
So if I can control the parafunctional forces, that patient may be able, it's fascinating, maybe be able to eat. I very rarely need to tell a TMD patient with joint pain, you need to eat soft foods. It's very rare because most of the time, those aren't the forces that hurt them. Now, if they're damaged enough until they get better, sometimes that's necessary. It's often usually not. Now, if I can, so wherever that, I don't care where that condyle is, it could be medial, it could be, if I can decrease the forces, I go into anterior midpoint stop. Yep.
So yeah, that's sort of what I thought, but you explained it so much better. So it's basically we're decreasing the forces, and that in itself will mean that the sort of what's happening in the anatomy, which is, we know, like we said right at the beginning of this episode, that actually there's only a defined position the condyle can go. It won't go all the way back.
So this is interesting, Jesse. What happens now in 2 months when the patient says, Dr. Barry, I don't have pain and I stopped clicking?
Okay.
What happened?
So one of two things could have happened. One of a lot more than two things. Okay, so the disc could have come back. Unlikely, I think, because like you said.
So let's throw that out. Okay, go.
Okay, so the disc could have come back. The other thing is that the posterior band has thinned a bit, so maybe it's changed morphology so that the click is much more subtle, so it's not audible to the patient as much.
That is really good.
Yeah.
So the number of people that would have come up with that, I have to tell you, is really so. So for those that are listening, when Jasneet said the posterior band, what he's referring to is the posterior rim of the disc. The posterior rim of the disc, which was responsible for that clicking because it was so thick, is if you decrease the forces and now they're no longer destructive, but they're within the patient's ability to adapt. Part of that adaptation becomes remodeling of the posterior rim from the pressure. Instead of doing damage to the ligament, it now is altering that disc. We've changed the direction forces, and now the disc is recovering, but with less veracity and now no noise. Mm-hmm. Really good. Really good. Some people would say, oh, now it's a disc displacement without reduction. And you'd say, no, because there's been no change in range of
opening. Exactly.
Yeah, there would be a change in range of motion suddenly in a young person, especially in a younger person.
As much as I don't want to be known as a TMD guy, but the more I spend time with you, it's like my inner geek coming out. But it's one of those really interesting joints. It's one of the most fascinating joints of the body, and I can't stop learning about it. So it's great, and to help our patients with parafunctional control, which I believe is the biggest source of consistent trauma to the joint,
right,
is a great thing to be part of.
Yep, very good. All good, always is.
Barry, thanks so much for coming on this on my show again. I'm gonna have to bring you back again because the next time, because I had some questions about sleep and airway, and I had so much, but time is of the essence, my friend.
Can I tell you that we really should do that, because there's an awful lot of myths out there and people are making a big deal about something that can be very, very important. But like everything else, there's that knee-jerk reaction to make it more important and more difficult and more complicated than it really is.
Well, let's make that happen. And I'm just going to leave 3 words that's going to make you probably feel sick inside, I imagine. Okay. And it's airway websites, orthodontic practices, marketing themselves as providing airway-friendly orthodontics.
It's sad. It's really, really sad. And please don't underestimate the incredible value of understanding the role of functional therapy in our younger patients mm-hmm. and the potential that it has. So I don't mean to underestimate that in any way, shape, or form. But it's our profession's habit to take some good information and take it out of perspective and make it a bigger deal because you can sell a course with it, or you believe in it. People often ask me, what do I believe in? And what's my response to that? You know that. What do you care? Who am I? What do you mean? What do I believe? It's not a matter of what I believe. I went through all that when I went through camp after camp after camp, and suddenly I realized that belief means religion, and religion is cultish, and it has nothing to do with science. If you ask me what the predominance of the evidence is, I'm very happy to tell you. If you ask me what I believe, what do you care? And unfortunately, they walk into these things. They want to know what is the belief, and these people are creating their own belief systems and their own models and their own techniques and their own, it's very disturbing.
Well, we have to come back to cover this sort of topic one day. It'd be very, very good to do so. Enjoy Florida, and I think I've done quite well. I don't think I touched my mustache as many times.
All fine. So does that mean you weren't thinking?
I don't know what that means. I don't know. I don't know what that means.
It's good. It's good. It's good. Please,
Brilliant.
I hope to see if anybody's actually listening to this.
If you made it this far through our TMJ mumbo jumbo, then well done. Firstly,
consider coming. We're very excited about it. This London trip. Has been just exciting to me. I really enjoy it. Initially, when I first came to London, Jasneet, I will tell you that I think my style was, at that point, it was 10 years ago, was kind of difficult. They weren't used to my presentation style, which was,
theatrical.
Yeah, a bit. and either Londoners have changed, our UK, the world has changed, or you've been watching the Parliament too much, and I seem calm. I don't know, but I so enjoy coming. The people are so eager to learn, and I am so appreciative of the difficult world in which you exist. I know the pressures of the national health system. I appreciate that, and my goal is to make your lives better safely.
Amazing. Well, I hope to see you in June myself, because I can't do the London date, but I probably can do the Glasgow one. So I'm going to take a flight to Glasgow to see you. So I'll see you then, Barry. It'd be nice to catch up over a drink. And again, I'm going to bring you back.
I would love that.
Brilliant. But we'll have to bring you back for an airway episode.
Sounds good.
Thank you so much for watching or listening all the way to the end. I really appreciate it. Please share it far and wide to your dental colleagues if you enjoyed it. And I'll catch you in the next episode. Like I said before, I've got so many recorded and lined up that I'm really excited to get them out. Some really great pediatric stuff. A really revelatory episode about how to look after your back as a dental professional, which is going to shock you. I kid you not. So I look forward to getting all that out there. And thanks so much for supporting my podcast by listening to it. And I'll catch you in the next one.